I got this opportunity, okay, to host this Spice Route India Gujarat chapter classroom. Diksha,
Yes,
Dr. Deeksha is second year DNB candidate from Sterling Hospital, Ahmedabad, and she'll be presenting a case of stroke. Okay, so Dr. Ashish Bavishi. Okay, he's a DNB family medicine and infectious disease consultant as of now. Okay, he has at least 8 international publications, and he is supposed to be a very good teacher. In fact, he taught me also during my residency. So, Diksha, thank you again for agreeing to participate. Okay, so don't worry, we were pretty nervous when we spoke first. Okay, this is how you present, this is how you learn. Okay, so thank you again. Okay,
thank you, ma'am, for giving me this opportunity.
Even we can have a small intro session, Dr. Sarin. Okay, I think we can start, Diksha.
So are we starting?
Should I start, ma'am?
Yeah.
Good evening to all the teachers. Myself, Dr. Deeksha, TNB Family Medicine resident from the Sterling Hospital, Ahmedabad. Today, I'm presenting a case. The history of this case is given by a patient husband, a 63-year-old female patient, housewife, and resident of Ahmedabad, presented with chief complaints of right side upper and lower limb weakness, difficulty in speech, and deviation of mouth to left since 2 days. History of presenting illness. Patient was apparently asymptomatic 2 days ago and performing her routine activities. Patient was last seen normal at midnight 2 a.m. 2 days back in morning at 5 a.m. when patient got up, she noticed weakness in right upper limb and lower limb. She was not able to wear sleepers and unable to hold glass of water. The weakness gradually progressed in next 2 hours. Then patient was not able to move her right leg and stand on it. Patient was not able to move her right arm. Patient also had difficulty in speech, which was sudden in onset and was able to understand command. Gradually, speech difficulty worsened over 2 hours and patient was not able to understand any command. Relative notice deviation of mouth to left side, which increases while speaking and eating. Patient was treated conservatively in a local hospital and was referred here for further management on 3rd day. There was no history of loss of consciousness, headache, fever, vomiting, no abnormal jerky movements, chest pain, palpitations, no bladder bowel complaints. There is no history of difficulty in swallowing, regurgitation, hoarseness of voice, and there was no history of trauma or head injury or any spinal injury. Past history. Patient is a known case of...
Just a moment.
Yes, ma'am.
Yes, Dr. Ashish, is Diksha audible?
Yes, she is audible. Shall I ask some questions during the history of presenting illness, or shall we wait for the history of presenting illness to finish?
You can ask. You can ask.
Okay, Diksha, go back a little bit. Yes.
Yes, sir.
So, according to the current history of presenting illness,
yes,
what are your 3 most important differential diagnoses?
Seizures, syncope,
okay.
and hemiplegia. So patient present with acute neurological deficits, according to history, then it looks like hemiplegia more.
Okay, but so how will you differentiate a seizure disorder from hemiplegia?
Sir, there was no abnormal jerky movements history given by patient relative, and sir, in seizure there is loss, post-ictal confusion also,
Okay.
and sir, there is no neurological deficit or weakness in any arm in seizures.
Okay. So you mean to say that in seizure disorder, there are no focal neurological deficit? Is that what you mean to say?
So in seizure, there is no weakness of arms and any limb. Neurological deficit can occur in seizure.
I must correct you, Diksha. In post-ictal state, there is sometime ascending or even descending or aggravating neurological weakness observed in limbs, which is a common complication observed in a post-ictal state. Okay.
Okay, sir.
And that is why that is a very important differential diagnosis, because the patient had an episode in the early morning. You have to think
Yes, sir.
about some kind of cardiac illness as well.
Yes, sir.
Okay. So syncope,
Yes, sir.
syncope may be neurological and it may also be cardiological in origin.
Yes. Yes, sir. Yes, sir.
Okay. So how will you differentiate a true seizure and a stroke?
So,
Clinically.
so true seizures. Sir, there is weakness in limbs. Weakness is present in limbs in stroke, and in seizure. So there is key movements like GTCH, typical GTCH seizure present with uprolling of eyes and jerky movements of upper and lower limb.
Okay.
And bite of the tongue and urinary incontinence. It can be seen in stroke also, urinary incontinence, but the typical GTCH seizure present like this.
Okay, so basically,
patient can have loss of consciousness also for a brief period of time.
So there are three important conditions that you need to clinically, you need to see in the patient. First thing, was there any observer present while the seizure was occurring?
Yes, sir.
So you confirm it by asking the observer, was there any kind of a GTCS activity noted?
Yes, sir.
Secondly, you need to see whether there is a bite, tongue bite.
Yes, sir.
Due to
tongue bite, yes,
tonic,
sir.
Due to tonic contraction of the jaws.
Yes,
so
sir.
usually the bite marks are present in the lateral aspect of the tongue.
Yes, sir.
And thirdly, there is either a post-ictal confusion or there is a post-ictal drowsiness.
Yes, sir.
Which is not present in stroke.
Yes, sir.
So this is how you differentiate between a seizure episode and stroke.
And stroke. Yes, sir.
Okay?
Yes, sir.
Okay, please continue.
Relative notice deviation of mouth to left side which increases while speaking and eating. Patient was treated conservatively in a local hospital and was referred here for further management. There was no history of loss of consciousness, headache, fever, vomiting, no abnormal jerky movement, chest pain, palpitations, no bladder bowel complaints. There was no history of difficulty in swallowing, regurgitation, hoarseness of voice, and there was no history of trauma or head injury or any other spinal injury.
Excellent. So why do you ask the negative history? By asking the negative history of chest pain, what are you ruling out?
So I want to rule out any arrhythmias or any cardiovascular cause of stroke.
Correct, correct, correct. Very good. Go on.
Yes. Past history. Patient is a known case of diabetes mellitus since 11 years and hypertension 6 years. There was no past history of epilepsy, peripheral vascular disease, stroke, cardiac disorder, thyroid disorder, asthma, TB, COPD, CKD, and CLD. There was no past surgical history, no past history of similar complaints. Drug history, on regular medication for hypertension and diabetes, and there was no history of use of anticoagulant or any other hormonal therapy.
Okay. So, please continue. Please continue.
Family history. Father and mother have type 2 diabetes mellitus and no other positive family history. Personal history. Patient is a known smoker and non-alcoholic, normal bladder bowel movements, normal vegetarian diet, and normal sleep and appetite.
Okay. So why is sleep pattern important when you elicit personal history in such patients?
So not sure about sleep pattern.
Not sure. Okay. So see, whenever you are presenting such a history, particularly of a neurological condition,
Yes,
you
sir.
should know the significance of whatever you are presenting. Particularly in the personal history, if you are saying that the patient has had normal sleep and appetite pattern,
Yes, sir.
you need to identify what consists of a normal sleep pattern, because in old age, the normal sleep pattern may be even 5 hours of sleep per day.
Yes, sir.
Okay, it may not necessarily be up to 7 hours or 8 hours of sleep, which is normally required of an individual.
Yes, sir.
Okay. And another thing is, at this age, usually other conditions may cause decrease in the sleep. So patients may complain that I have had a decrease in the sleep quality since the past 3 to 4 months. And upon inquiring why is that so, they may say that there is some kind of a throbbing headache, or there is some kind of some stress related conditions which may hamper the sleep quality at this age. So why is throbbing headache important at this age?
Sir, because of hypertension, throbbing headache is in subarachnoid hemorrhage.
Yes.
There is immense headache, and which subarachnoid hemorrhage can also present as stroke.
Excellent. Very good. Very good. And second? Vascular headache.
Yes, sir.
So vascular headaches, particularly temporal arthritis, present at this age.
Sir. Yes, sir. Yes, sir.
Okay, so temporal arthritis may present in the middle age. About the individual is about 50 years of age, predominantly female, and they may present that as an indolent history of throbbing headache, which is acutely life-threatening if not treated.
Yes, sir. Yes, sir.
Okay, that is why sleep pattern is important. So when you are presenting such a patient of a neurological case, you need to identify and answer appropriate questions regarding each and every elements of the personal and family history.
Yes, sir.
Okay. So why do you ask about that in this patient?
Sir, most of the time when patient takes non-vegetarian diet, Then there is chances of neurocystic cirrhosis also when they eat non-veg.
Okay.
It can lead.
So how does neurocystic sarcosis present to you?
So neurocystic cirrhosis case mainly present with seizures episodes, sir,
Okay.
and headache.
Headache and seizures.
Sir.
Oh,
Yes, sir.
usually the patients present with seizures. Okay.
Yes, sir.
But how will you identify whether the patient has had normal vegetarian diet? What do you mean by normal vegetarian diet?
So normal vegetarian patient take adequate amount of vitamins and calories.
So have you asked this patient how much vitamin intake she takes? What micrograms or what are the doses
No,
of
sir.
vitamins she takes?
No, sir.
Yeah. So never utter that the patient has had normal vegetarian diet. He is vegetarian.
Yes, sir.
That's all you need to answer.
Okay, sir.
Okay. What are the kinds? What is what are the stroke preventive diets?
So green vegetables and so walnuts and PUFA derivatives.
What is Mediterranean diet? What is a Mediterranean diet? See, there is a very easy way to remember. A Mediterranean diet is a colorful diet. You need to have different kinds of colors. Colorful
So
vegetables.
vitamin A rich diet.
So all these, so not only vitamin A rich diet, but different kinds of colorful diet. Colorful diet means, so if you include purple in your diet, that means you need to consume purple cabbages. If you incorporate yellow in your diet, you need to have yellow bell peppers consumption in salads, green leafy vegetables, dates,
Yes, sir.
olives. Okay, so these are all typical of and tomatoes, red again. So these are all this all consists of Mediterranean type of diet, which are rich in antioxidants, which are rich in natural flavonoids and natural neuro and cardioprotective elements.
Yes, sir.
Okay. So whenever you ask, you also have to ask about diet in the patients of stroke. Particularly, vegetarian diets are usually those kind of diets which are not vitamin B12 rich diets.
Yes, sir.
Okay, so in those
Yes,
kind
sir.
of diets, there is a chance or there is a very high chance that the patient may be suffering from hyperhomocystinemia.
Yes, sir.
Okay, so this
Yes,
particular
sir.
condition is also associated with strokes.
Yes, sir.
Okay, what else
Yes,
do you
sir.
ask? Do you ask about alcohol intake?
Yes, sir. I have asked about the alcohol. Patient was
Okay.
non-alcoholic and non-smoker, sir.
Okay, is there any normal intake of alcohol associated with protective neuro and cardio protective elements?
Yes, sir. So 90 ml of so alcohol per day, sir, is beneficial. It increases HDL and therefore and helps in
Okay, okay.
preventing
So,
stroke, sir.
so red wine is associated
Yes,
with associated
increasing
with
HDL.
yes increase in the good amount of HDL.
Yes, sir.
Okay, and
Yes,
it
sir.
is also cardio and neuroprotective.
Yes,
But
sir.
that does not mean that you have to start advising all the people to start drinking
Yes, sir.
alcohol.
Yes, sir.
Okay,
Yes, sir.
fine. So at the end of this, so does this conclude your history of presenting illness?
Yes, sir.
Okay, so what are your differential diagnoses now?
So this is a case of right side hemiplegia and with aphasia and so, involving right side of face.
So differential diagnosis?
So stroke, sir. Acute stroke.
Acute stroke.
Yes.
So
Sir.
that is your primary diagnosis, and you are very certain that the patient is having stroke.
Yes, sir. Yes, sir.
Okay, then I'll have to ask what are stroke mimics?
Stroke mimics, sir.
What conditions are known as stroke mimics?
So seizure.
Seizure, okay.
So migraine can also mimic like the stroke when migraine present with aura, and sometimes it is difficult to differentiate between a migraine and a stroke until unless MRI there was no abnormality in MRI. Then migraine can also be present like.
So how will you differentiate between a migraine with aura and stroke?
Sir, on imaging, there is no abnormality seen in MRI while in migraine, but in stroke, on imaging there is abnormality. Maybe it is due to ischemic or due to hemorrhagic, sir.
On MRI?
Yes, sir. Imaging, sir.
Okay, if say the patient presents to you within 30 minutes of weakness, hemiparesis, and
not sir,
you do MRI.
not completely as such that type of gross hemiplegia or hemiparesis, but in some cases it presents like some weakness in migraine patient.
So if the patient presents to you with the hemiparesis, right side hemiparesis, and you do an MRI and the patient has come within 30 minutes of presentation.
Yes, sir.
What will you see in MRI?
It can be due to, if it is due to ischemic stroke, then on MRI we can't, it is not conclusive of anything.
So how will you differentiate?
Sir,
in that
patient
case,
give
what will you do?
patient give recurrent history of headaches.
Headache.
Yes, sir.
Okay. What else?
And so before beginning of headache, patient have other symptoms like migraine with aura, like scintiform vision, and nausea.
Okay, ancillary signs. Okay.
Yes, sir.
Okay. But can it be present also in stroke?
Yes, sir.
So
in stroke also, sir.
So how will you differentiate? So there is a general dictum. There is a general dictum.
Yes,
if
sir.
a patient is presenting to you in an emergency condition with either hemiparesis,
can be also differentiated.
Yes. So now you are covering other stroke mimic condition. So first of all, you should never think of migraine.
Yes, sir.
You should never think of migraine with aura as a differential diagnosis. If you think that the patient is coming to you with stroke and the patient has had migraine, what will happen? What will happen?
Yes, sir.
If the patient comes to you with stroke signs and your first differential diagnosis is migraine with aura, what will happen?
No, so we will lose the window period we have.
Not
save
only
the
will you
patient.
lose the window period, but you will lose not you will lose a very vital time wherein you have to take a quick decision to treat these patients.
Yes, sir.
Okay.
Yes,
So
sir.
you have to rule out stroke mimics within 15 minutes of presentation.
Yes, sir.
So one is seizure. Fine. That I can understand. What else?
So subarachnoid hemorrhage.
So that is part of stroke, isn't it?
Yes, sir.
So that is a part of stroke. I am asking about stroke mimics. Mimics means conditions which mimic stroke.
So hypoglycemia, hypokalemia, or hyperkalemia also can present limb weakness, which
Correct.
can also mimic like stroke.
Correct. So hypoglycemia, metabolic conditions. Metabolic conditions like hypoglycemia, hypokalemia, hyperkalemia can mimic as
Yes, sir.
stroke. Very good.
Yes.
Next.
Yes, sir. And sir, any muscle atrophy? No, sir.
Polyneuritis. Do you mean to say polyneuritis?
Yes, sir. Sir, acute inflammatory transmyelitis can also, GBS can present like stroke also. Granberry
GBS.
syndrome. Yes, sir.
GBS can present as stroke.
So because of
Okay.
weakness, we can think it like as a stroke.
What kind of weakness do you usually see in GBS?
So flaccid paralysis of lower limb, mostly it start distally distally, and it is of flaccid type, rubber type of legs.
So is it hemiplegia or is it paraplegia?
So it is paraplegia.
Okay, so will stroke conditions present as paraplegia?
Yes, sir.
Which kind of strokes present as paraplegia?
Sir, if there is lesion at spinal cord level, sir.
So does that constitute a stroke?
No, sir. No, sir.
So usually whenever there is stroke, it is assumed or it is clinically in a patient having stroke, it is assumed that there is some kind of a vascular accident in the brain and not the spine.
Yes, sir.
Okay. So it
Yes,
may
sir.
be brain matter, it may be white matter, it may be sub-white matter nuclei like extrapyramidal and pyramidal tracts and other basilar nuclei, basal ganglia, thalamus, and cerebellar. Okay.
Yes, yes,
So
sir.
usually paraplegia is of the origin of spinal cord or
Yes, sir.
high spinal cord, high motor neuron lesions.
Yes, sir. Yes, sir.
So that brings us to another question. What are the differences between UMN and element lesions?
So human lesion mostly present human lesion present with the tone of the muscle is hypertonic in human type and hypotonic in element type, and the human lesions are
Sorry,
sir,
I didn't get you. Can you speak? I think there is some disturbance in your voice.
so there is hypertonia in human lesion and hypotonia in element type of lesions.
Okay.
And thus, deep tendon reflexes are exaggerated in human type of lesion, and these are absent in element type of lesion. And muscle atrophy is seen in element type of lesion, and fasciculation is seen in element type of lesion, while clonus is seen in human type of lesion.
Okay. So where do you look for fasciculations in element type of lesions?
So on muscle groups, on small muscles.
Particularly where?
Sir, bicep.
So usually if there is, yeah, so small muscle groups, basically either the flexor muscle groups or extensor muscle groups in the limbs. And most importantly, you can look for fasciculations in the tongue.
Yes, sir.
Okay,
Yes, sir.
fine. Please continue.
Summary of the cases. A 64-year-old female, known case of hypertension and diabetes mellitus, presented with sudden onset of weakness in right upper and lower limb with difficulty in speech and deviation of mouth to left side. The above history suggests right side hemiplegia with right side facial palsy and aphasia.
So you have
sir,
to,
this,
Diksha, remember, you have, whenever you are presenting or summarizing at the end of
Yes,
history
sir.
of presenting illness,
Yes, sir.
you should mention what is your primary diagnosis and then differential diagnosis that you would like to rule out.
Okay, sir.
Okay.
Yes,
So
sir.
you have to mention the differential diagnosis in your history of presenting illness at the end of the history of presenting illness in your summary.
Yes, sir.
So if you say like stroke or seizure disorder or some kind of toxic encephalopathy or metabolic encephalopathy, you have to mention it.
Yes. Yes, sir.
Okay, it may also be intracerebral intracranial space occupying lesion.
Yes, sir.
Okay, so all just write down 1, 2, 3, 4, and 5. These are your differential diagnoses at the end of your history of presenting illness.
Yes, sir.
Okay, let's continue with the general examination.
On general examination, patient was lying in bed in supine position, upper limb flexed and adducted and lower limb extended and externally rotated. Patient was conscious and cooperative. The overall appearance of the patient is well nourished and average in build. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema.
Continue.
On vitals were patient was febrile on touch. Pulse rate was 90 beats per minute regular, normal in volume, no radio-radial delay and no radio-femoral delay, and normal arterial wall thickening. Respiratory rate is 16 per minute regular and thoraco-abdominal type. BP was 166 by 90 mm of Hg in left hand in supine position, and saturation was 97% on room air.
Okay.
Sir, I would like to examine central nervous system first.
Okay, so at the end of your general examination, have you
Yes, sir.
tried to narrow down your differential diagnosis? Has your differential diagnosis narrowed down? Has any kind of a differential diagnosis ruled out? Dr. Deeksha?
Yes, sir. Yes, sir.
Are your differential diagnosis still the same after general examination?
No, no, sir. Sir, I will go for stroke only for this.
No, I'm asking
The
about
typical-
differential diagnosis. So at the end of your history of presenting illness, you mentioned four differential diagnoses. Which were there?
Sir, seizure, stroke, hypoglycemia, or any metabolic encephalopathy or metabolic component cause.
Why not cardiac? Why not cardiac?
Sir, but cardiac can be cause of stroke, but it can be in differential diagnosis.
Okay. Would you like to rule out seizures now on the basis of the patient's overall general condition?
Yes,
Why would you like to rule out seizures?
the patient was conscious and patient was cooperative and not drowsy.
Okay. So when did the patient present to you?
So patient presented to on the third day.
On the third day
On third day, yes, sir.
after initial signs, initial symptoms.
Yes, sir.
So what about postictal confusion and postictal drowsiness? Can the patient present to you on third day of a
No, sir.
seizure disorder
sir.
with conscious and cooperative state?
Sir, postictal confusion stage remained for 1 to 2 hours only.
Are you
And
sure?
if it is due to yes, sir.
What about status epilepticus?
Yes, sir. And this postictal confusion lasts long.
Yes. So postictal confusion is usually associated with about 4 hours to a day of postictal confusion. But if the patient, as you rightly said, is presenting to you on third day of symptoms, and it still very well can be a seizure disorder, isn't it?
Yes, sir.
Isn't it?
Sir, if the patient had an episode of seizure, then there is not any weakness or the position of his her limb shows it
So why
like
did you? So you missed a very important general examination feature for ruling out
facial
seizures.
appearance, sir.
For ruling out seizures,
Sorry, sir.
you missed a very important general examination. Did you examine oral cavity?
No, sir.
So why is the oral cavity examination important?
Sir, for the tongue bite.
Yes, and what did we discuss?
So tongue bite is present on the lateral side of
Yes.
mostly.
Yes, and
In
what else did we discuss? What else did we discuss? What about fasciculations?
Yes, sir. Yes, sir. Fasciculations.
And what else? What else?
I'm not able to recall.
So just go down. You mentioned something about the respiratory pattern.
Yes, sir.
So
Thoraco-abdominal type.
what
regular.
was the respiratory pattern?
Sir, it is regular and thoraco-abdominal type.
So do you have anything to comment on this?
Sir, in case of a stroke, if it is medullary infarct or any pontine infarct, then brainstem infarct, then respiratory rhythm can be irregular.
Correct.
Like any stroke breathing, sir, pattern.
Correct. So basically you are trying to localize. So after each and every aspect of your examination, you are trying to localize the lesion. See, the CNS presentation of a CNS case is all about trying to localize the lesion to where in the CNS pathway the area of localization of the lesion is. And
Yes,
hence it will differ and narrow down your differential diagnosis.
yes, sir.
Okay, continue.
Yes, sir.
Continue.
Sir, on examination of central nervous system, first higher mental functions are checked. Patient was conscious. Patient was right-handed, and orientation, intelligence, and memory can't be assessed in view of global aphasia, and speech. Global aphasia was present, sir.
Continue.
On cranial nerve examination, all cranial nerve examination was normal except right side human type facial palsy.
So how did you examine for UM and facial nerve palsy?
Sir, I checked. Sir, in human type of facial palsy, sir, there is sparing of upper face, and I asked the patient to close his eyes. And on the right side, the patient is not able to close his eyes properly. And sir, and I asked the patient to wrinkle his forehead. The patient is able to wrinkle his forehead. So this ruled out element type of palsy.
Correct.
And
correct.
And
Okay. How did you determine whether the patient was right-handedness or left-handedness?
so his relative or his husband told us that patient is right-handed.
But you are examining the CNS examination, no?
Yes, sir.
Now you have entered into systemic examination, CNS examination. So everything becomes highly specific. Whatever you are performing on the patient, and you are not asking any more history.
Yes, sir.
So now you are eliciting. You are eliciting the signs.
Sir, that patient have aphasia, global aphasia, that indicate that
Correct.
Patient left hemisphere is dominant, and patient may be right-handed.
So just on the basis of your speech difficulty or speech aphasia, you determined whether the patient was left-handedness or right-handedness? Is that true?
Sir, no, sir. We can't be specific only about speech.
Very good.
Because in left-handed people, in 70% of left-handed people also, left hemisphere is dominant. Sir.
Correct. So never mention it if you don't know.
Yes, sir.
Okay. What are the types of aphasias?
Sir, Broca's aphasia or motor aphasia, Wernicke's aphasia or sensory aphasia, and global aphasia.
Okay. So this patient had global aphasia.
Yes, sir.
So on the basis of this, where would you localize the lesion?
So global aphasia, that means Broca's aphasia, motor area, that is Broca's area, Wernicke's area, both areas are involved. That it suggests that there can be infarct in middle cerebral artery.
Correct. Very good. Continue.
So on cranial nerve examination, all cranial nerve examination is normal except right side human type facial palsy. On motor function examination, there was no muscle wasting. On examination of tone, on right side upper and lower limb are hypertonic, and on left side tone was normal. Power.
Okay.
Yes. Power was on the right side. All the joints of upper and lower limb power was 2/5. That is the moment. The anti-gravity when we eliminate the gravity.
Oh, that's fine. 2/5. That's fine. Continue.
Yes, and on the left side, the power was normal, 5/5. coordination on the right side can't be assessed, and on the left side it's normal, and there was no involuntary movements noted.
Okay.
So sensory functions can't be assessed as due to global aphasia. And
Why sensory
Sir-
does so is speech the only part of your sensory function? What
sir,
about
because of
gross sensation? What about fine sensation, temperature?
So because
pain?
of global aphasia, yes, sir.
So can you determine all these kind of sensations on the patient if there is a global aphasia?
So patient can tell us about the gross pain and temperature changes, but can't tell us about the fine changes and cortical, that is 2-point discrimination and that thing.
Okay. In global aphasia, is comprehension affected?
Yes, sir. Global aphasia comprehension is poor, repetition is poor, and non-fluent speech, sir.
Okay. So patient will not be able to understand you.
Yes, sir.
Okay. But can they assess? Can you assess whether there is pain sensation?
So patient can react when we give pain stimulus to her gross.
So at least you can localize pain, isn't it?
Yes, sir. Yes, sir.
So you have to mention in sensory function regarding the level of pain. Why is pain important?
So for thalamic pathways
So basically, in a neurological patient, if the patient is having hemiplegia, you need to assess the level of pain. Level of pain in the dermatome, isn't
Yes,
it?
sir.
You
Yes,
as
sir.
you rightly pointed out that the patient had and facial palsy,
Yes, sir.
right? So
Yes,
was it
sir.
on the right side or was it on the left side?
The right side, sir.
Right side. So how will you determine whether the patient's trigeminal nerve is not involved?
Yes, sir.
So you need to assess the pain. At least you have to mention the pain, level of pain. And it is particularly important to determine whether there is involvement of the cranial nerves or not, isn't it?
Yes, sir.
And I think you mentioned in the cranial nerves that only facial nerve was involved.
Only facial nerve is involved, sir.
So if you have not determined how the pain sensation is there or not, how did you determine whether trigeminal nerve involvement was there or not?
So the sensory function of trigeminal nerve was not assessed, but the motor function of trigeminal nerve, like opening of mouth, the masseter and temporalis are working. So I think that trigeminal nerve is spared in this patient.
So is trigeminal nerve a mixed nerve, motor nerve, or sensory nerve?
So it is a mixed nerve. It have sensory functions and motor functions both, sir.
And what are its branches?
Sir, ophthalmic, maxillary, and mandibular, sir.
So all three branches have mixed sensation, or all three have some kind of motor and sensory sensations?
Sir, different type of sensation. Ophthalmic have motor function. Maxillary have sir mixed sensory and motor, and mandibular have motor function, sir.
So ophthalmic has mixed function?
Sir, ophthalmic. Yeah. Yes, sir. Sir, I'm not sure, sir.
Not sure. Okay. So you just say when you are not sure, you just say not sure. Okay.
Yes,
so
sir.
ophthalmic is sensory. Okay, and
Okay, sir.
we have very distinct clinical condition associated with trigeminal nerve inflammation, which is known as trigeminal neuralgia.
Herpes, trigeminal neuralgia, sir.
Neuralgia. What is herpes zoster ophthalmicus?
Sir,
Again, it is the infection of the
infection of trigeminal ganglion, sir.
trigeminal ganglion, particularly of the ophthalmic division.
Yes, sir.
Okay, and that is why there is herpes zoster. The distribution of the lesions are in the pathway of the herpes zoster of the ophthalmic division of the trigeminal nerve,
Yes, sir.
which is sensory.
Yes, sir.
Okay,
Yes, sir.
and how will you elicit sensory pathway of the ophthalmic division of trigeminal nerve?
Sir, corneal reflex, sir.
Correct, and conjunctival reflex.
Yes, sir.
Okay,
Yes.
fine. Continue.
On examination of reflexes, superficial reflex like abdominal reflex was absent on right side and normal present on left, and plantar reflex was extensor on right side, and all the deep tendon reflexes are exaggerated on the right side and present normally on the left side.
Okay. Next.
Cerebellar function, no nystagmus, and other cerebellar functions can't be assessed.
Correct. So cerebellar functions cannot be assessed because of patient's CNS condition. Fine. So
Yes,
that's
sir.
fine. You can just utter it in your clinical examination whenever you are presenting a case that the cerebellar functions cannot be assessed.
Assessed.
Right? Fine.
Yes, sir.
Next.
So gait can't be examined, and signs of meningeal irritations was absent, and spine and cranium was normal, sir.
So why did you ask for meningeal irritation in this patient?
So because, so in case of chronic meningitis, also patient can present like stroke due to chronic inflammation, and therefore we have to do.
Okay, but you did not mention in your history of presenting illness, at the end of history of presenting illness, in your differential diagnosis, you did not mention your meningeal irritation or meningitis. Your differential diagnosis did not
Yes, sir.
involve meningitis as a part of differential diagnosis. So why mention meningeal irritation?
So it is a part of CNS examination, meningeal irritation.
It is part of CNS examination, but since your history of presenting illness did not have differential diagnosis of meningitis, what is the most important symptom of meningitis?
So headache,
And
fever.
did the patient have fever?
No, sir.
Then
Sir,
do
I
you
have
think you...
mentioned it in HOPA that patient has no fever and headache.
Yes, so do you think you need to look for meningeal signs? No. You should not.
Okay, sir.
Okay, continue.
Okay. Spine and cranium was
See,
normal.
the thing is, you need to simplify. You need
Yes,
to
sir.
simplify your case presentation in such a way that you are presenting your CNS case in a very, very systematic manner. And
Yes,
you
sir.
leave no scope for the examiner to harass you.
Yes, sir.
Okay. When your differential diagnosis does not contain a particular clinical condition, and you again deliberately or accidentally mention that kind of a clinical sign in your systemic examination, you are playing with fire,
Okay, sir.
right? So when you particularly say signs of meningeal irritation, your entire CNS presentation will go on chronic meningitis, other kinds of meningitis, fungal meningitis, viral meningitis, meningoencephalitis, which you do not want to, which you don't want to get into. Your particular area of interest is in stroke only, and you are presenting a
Yes.
patient in stroke. Why do you want to go into all these details? Unnecessary details. Do not, the dictum here is do not lead the patient examiner into a territory wherein you are not familiar.
Okay, sir.
Okay.
Yes, sir.
So you are like a captain. You are like a captain of a boat where you are leading your examiner. The examiner is a passenger. Wherever you lead the boat, the examiner will also go there.
Yes, sir.
Okay.
Yes, sir.
Fine. Next.
Examination of other systems like cardiovascular, respiratory, and per abdomen examination was not significant.
Correct. Do not mention anything because your case is primarily of CNS. You just mention CNS. That's all.
Yes, sir.
Fine. So what are your provisional differential diagnosis now at the end of systemic examination?
So my provisional diagnosis is the case is probably due to acute ischemic stroke in the left middle cerebral artery, thrombus or due to thrombus, which may be possibly due to atherosclerotic disease.
So why not hemorrhagic stroke?
Sir, the case doesn't look like the BP was when the patient comes in ER, the BP was not that much high, and sir, in hemorrhage, the hemorrhagic stroke sir gradually progressed, and while the thrombotic stroke progressed within hours, and hemorrhagic stroke takes more time, and it is hemorrhagic stroke. There is a patient present with nausea, vomiting also, and patient is much more drowsy in hemorrhagic stroke, sir.
No,
Clinical.
no, you presented so well. But you need to also understand, beta, ki whenever you are presenting, you have to keep in mind that when you are presenting, if you think that your differential diagnosis is stroke, it may be ischemic or it may be hemorrhagic. You do not know how the patient will present in. So if you think
Yes, sir.
that the patient is having ischemic stroke, on your basis of provisional diagnosis, will you thrombolize this patient?
No, sir.
Why will you not thrombolize this patient?
Because I'm not 100% sure, sir.
So then why speak that the patient is having ischemic stroke?
So clinically, it looks more likely ischemic.
See, if you are
So,
saying that the patient is having ischemic stroke and you are localizing it that the patient is having middle cerebral artery stroke and it is
yes,
ischemic
sir.
stroke, you are very certain, you are almost 100% certain. You do not leave scope for any future examination or future tests, which is a wrong thing. Do you understand what I'm trying to
Yes,
say?
sir. Yes, sir. Yes, sir.
So whenever you say that the patient is having stroke, just tick. It may be ischemic, it may be hemorrhagic.
Hemorrhagic, sir.
And I would like to rule out hemorrhagic stroke and ischemic stroke by doing further tests.
Yes, sir.
Again, you are the guide, you are the captain of the ship, you are the captain of the boat. You have to guide the examiner.
Yes, sir.
Okay.
Yes, sir.
So according to you, this is stroke. So how will you differentiate between an ischemic stroke and a hemorrhagic stroke?
So clinically, there is.
No, wait. Let me stop you there. Let me rephrase my question. How will you determine whether this patient is having ischemic stroke or a hemorrhagic stroke?
So clinically, it is more difficult to differentiate between an ischemic and hemorrhagic stroke, but sometimes the hemorrhagic stroke patient present with high BP, more high BP, and the hemorrhagic stroke progress gradually, more gradually, sir, than
Again,
ischemic strokes.
let me ask you in further detail, what would you like to do? What would you like to do to differentiate whether this is an ischemic stroke or a hemorrhagic stroke?
So I will go for CT, sir, to make sure this is
Okay.
ischemic or
Okay, CT
CT
scan of the head.
of brain. Yes, sir. Head.
Okay, so why not MRI?
So MRI takes long time, around half hour, around 30 minutes, and CT and in MRI, ischemic stroke is not. So CT is the best option as it is fast, and if there is a hemorrhage, then in CT we can rule out that there is
Okay.
hemorrhage.
But in this particular patient, would you do a CT scan or would you do an MRI?
So in this particular case, I would directly go for MRI brain,
Why?
because I'm suspecting, sir, this is a ischemic stroke. And sir,
Your reasoning is not matching your.
yes, sir. Sorry, sir. Sir, in the starting to, sir, but the patient present in the on the third day, so we can go for MRI.
Yes.
MRI.
So your window period has long passed.
Yes, sir.
Window period for thrombolysis has long passed.
Yes, sir.
So by doing unnecessary CT scan examination, as it is, you are going to do an MRI examination.
Yes, sir.
So why do you want to do CT scan? Directly go for MRI.
Yes, sir. Yes, sir.
Okay. If the patient
Yes,
is
sir.
presenting to you in second hour of weakness,
yes, sir. Yes, sir.
then you go for CT scan.
Yes, sir.
Okay.
Yes, sir.
Fine. Anything else that you would like to do in this patient?
So then necessary blood investigations and ECG.
Okay. So what are the
ECG.
what blood investigations would you like to do in this patient?
So normally CBC, sir, RFT test to check for creatinine and CKD disease, and lipid profile, and LFT.
LFT.
And
Okay.
serum
Why LFT?
homocysteine level.
Why LFT?
Sir, LFT, sir, for PT, APTT, and
Why LFT in this patient? Are you looking for anything specific by doing LFT examination?
sir, I only want to check for PT, APTT.
PT, APTT. Okay. So you would like to check for any hemorrhagic or coagulation abnormalities.
Yes, sir.
Is that right?
Yes, sir.
Okay, fine. Next.
Sir, serum homocysteine level.
Correct. Why would you like to check for serum homocysteine levels?
Sir, increase homocysteine can lead to stroke, sir.
And why there is a specific clue in your history? Which is that clue?
Sir, patient father and mother have diabetes.
No, very important clue.
Normal vegetarian diet, sir. Vegetarian diet, sir.
Normal, so vegetarian diet. Yes.
Yes, sir.
So vegetarian diet is associated with hyperhomocysteinemia. We discussed it.
Yes, sir.
Isn't it?
Yes, sir. Yes, sir.
Okay. What will you look for in CBC?
Sir, anemia, normal, or blood count, if is it infectious or not?
Infectious. Okay. Why would you rule out any infections in cases of stroke? So let me rephrase it. What are the different complications of stroke?
Complication, sir, the long-term complication of stroke is like due to we catheterize the patient. There can be urinary tract infection. In case of airway compromised, we intubate the patient, and there can be ventilator associated pneumonia in the long term. And
I am asking only for complications associated with stroke.
increased intracranial tension.
Okay, excellent.
Which causes
Cerebral edema.
yes, sir. There is cerebral edema, which can also lead to papillary edema and decreased vision.
Name 5 most important causes of complications of stroke. Three most important causes.
So, bad source, sir.
Pressure sore. Excellent. 1. What are the causes of fever in a patient of stroke?
Causes of fever.
In a patient who has fever, in a patient who has stroke, what are the causes of fever?
So
After stroke.
After stroke. Sir, due to pneumonia, sir, respiration pneumonia.
Correct. Correct. Pneumonia. Next.
Sir, DVT, sir.
DVT. Very good.
Neurosis.
And UTI.
Yes, sir, UTI.
Okay. So
Yes, sir.
most important complications and post-stroke complications are, you named 3. One is
Yes,
pressure
sir.
sore, DVT, pneumonia.
Yes, sir.
Other complications are UTI, cerebral edema, epilepsy or seizure disorder,
Yes, sir.
and cardiovascular abnormalities.
Yes, sir.
Okay. What is
Yes,
stroke
sir.
heart syndrome?
Stroke heart syndrome.
Stroke heart
No.
syndrome.
Sir, I don't
Do you
know.
know or do you not know?
No, sir, I don't know, sir.
You don't know. Okay. So what are the conditions associated, hematological conditions associated with stroke?
Hematological condition, sir, increased hypercoagulable state.
Okay.
State.
So when you do CBC,
Yes,
what
sir.
is the most important aspect that you look for in a patient of ischemic stroke?
Thrombocytosis, sir.
Thrombocytosis. Next.
Anemia, sir. In rare cases.
Anemia.
Sir.
Okay. Why anemia? Why anemia?
Sir, in severe anemia, the blood perfusion decreases, so it can lead to ischemia in the.
Is hemolytic anemia associated with stroke?
No, sir.
Name a condition. Name a condition which is also a condition part of hemolytic anemia which is associated with stroke.
Sir,
Which hemoglobinopathy is associated with stroke?
Sickle cell anemia, sir.
Correct. Sickle cell anemia. What about polycythemia vera?
Yes, sir. Polycythemia, there is increased blood components which can lead to stroke, sir.
So what happens in polycythemia vera?
So there is a three lineage system that is red blood cells, white blood cells, and platelet both increase in polycythemia vera, sir.
So how will you look for what are the diagnostic clues to look for in polycythemia vera?
Sir, HB more than 18, sir. PCV more than 45, sir. And there is thrombocytosis and JAK2 mutations, sir.
Correct. Okay. So do you know about, so we discussed about stroke heart syndrome. Do you know anything about Takotsubo cardiomyopathy?
Yes, sir. Yes, sir. Yes, sir.
What is Takotsubo cardiomyopathy?
Sir, there sir, it is a stress cardiomyopathy. Due to stress, the shape of the heart is sir chamber like.
Go on. You are on the right track.
Sir, in Takotsubo, sir, the coronary arteries are normal, but the shape of the heart is there is
Coronary
global
arteries are normal.
hypokinesia. Yes, sir.
So Takotsubo cardiomyopathy is a sudden but transient LV
Yes,
apical hypokinesia.
Yes,
It
sir.
is stress induced, can occur in stroke, and how will you diagnose it? It also mimics acute coronary syndrome.
And STEMI, sir. Yes, sir.
Yes, it mimics acute coronary syndrome, wherein there is chest pain, there is ST elevation and elevation of the cardiac enzymes. But
Yes, sir.
2D echo will show LV ballooning and angiography will show normal coronaries.
Normal coronary arteries.
And it particularly occurs as a result of catecholamine excess in
Yes, sir.
post stress or also even after stroke. What are the what are the common causes of death following stroke?
What are the common causes of
Death.
death after stroke, sir? Sir, if the stroke is due to arrhythmia like atrial fibrillation,
Correct.
and sir, stroke associated with myocardial infarction, sir.
Correct.
And,
What else?
increased intracranial tension, which can lead to brainstem herniation, sir.
Yes. Excellent. How will you manage if the patient now presents to you in this particular patient? If the patient
Yes,
presents
sir.
to you on third day of presentation, and now you
Yes,
have
sir.
diagnosed it as an ischemic stroke,
Yes, sir.
how will you treat the patient further?
Sir, we have lost the window period, so now we will we will go for the exact cause of ischemia. So
how will you treat this patient?
sir, dual antiplatelets, sir.
Okay, what else?
And so we will go for MR angiography to rule out if there are any stenosis or
MR angiography. Okay.
Yes, sir.
Okay. So you have ruled
And
out everything, and now it's just a plain MCA territory infarct associated with ischemic thromboembolic episode. Now what will you do?
So, antihypertensive or antiplatelet drugs, sir.
Okay.
For long term.
Okay. What else? What else would you
Diabetes
like to give in
control.
this patient?
Statin, sir.
Okay, excellent. Why would you like to prescribe statin in this patient?
Sir, because sir, hypercoagulable state. So there is an increase LDL, VLDL, and cholesterol. So to decrease the amount, decrease these.
So the most important aspect of management of the stroke is
So statins also have anti-inflammatory property also.
yes,
So,
and
and
it also has
decrease the chances of plaque formation or clot formation, sir.
it has plaque stabilizing, atherosclerotic plaque stabilizing properties, which reduce the chances of further stroke. And because you are a family physician, would you also like to do some kind of preventive management in this patient?
Preventive management, sir.
What are the disability scores that you would like to calculate?
Yes, sir. Yes, sir.
What are the different disability scores that you would like to calculate in this patient? And why is it important to calculate disability scores?
So I would refer the patient for PMR center and physiotherapist for rehabilitation.
Okay. Physiotherapy centers. Okay. Where else?
And no, sir.
So are you aware of any kind of a disability scores after stroke, the calculation of any kind of disability scores?
Sir, ABCD square score, sir.
ABCD square. Okay. So
Sir,
what?
but it is for TIA, sir.
So that is for TIA. What I'm asking specifically about disability scores. Are you aware?
Sir, NYHS score system.
NYHS score. NYHS score is for heart failure, isn't it?
Yes. Yes, sir. I got confused, sir. Sorry, sir.
So what is modified Rankine score? Are you aware of modified Rankine score?
Sir, I have only heard the name of it, but no, sir.
Okay, so just read about modified Rankine score. What are its implications? So how will you calculate the prognostic outcome of the patient's disability? So there are many studies which have shown the application of modified Rankine score.
Yes, sir.
And how to implicate it in a day-to-day practice of your OPD as well as post-stroke rehabilitation programs.
Yes, sir.
Okay. So I think this concludes our session for stroke examination and history of presenting illness, general examination, systemic examination, and management of stroke patient.
Yes.
Do you have any questions?
No, sir.
Fine. I think this concludes. So we conclude this session on my side. Dr. Sona, do you want to take over? Dr. Sona, you're not audible. Dr. Sona? Fine. So let's conclude this session. I think there is some issue with Dr. Sona's audio. Let's conclude this session. And I think Dr. Serin and Dr. Sona will get back to you on the group.
Yes, sir.
Okay.
Okay. Thank you, sir.
Thank you.